good. This morning, it's a pleasure to have Dr. Raul Ramos as our guest speaker. Dr. Ramos is a clinical professor of surgery in the department. Dr. Ramos is originally from Monterrey. Hey, good? All right. And grew up there, went to medical school there, which, as you know, is like 6 years of college and medical school together. He then is a graduate of this general surgery residency, followed by a colorectal fellowship at the Mayo Clinic. He then came back to San Antonio and has been in the practice of colorectal surgery since 1973. He's also fully participated in the Department of Surgery since that time, and more recently, in the past year, kind of joined the faculty on a 40% time. And this morning, he's going to be talking about his experience with inflammatory bowel disease. In particular, is it just going to be regional enteritis or ulcerative colitis too?
You're here.
The whole enchilada. Okay. I told him I would be up here signing Ramos into English. Thank you.
Thank you. Thank you, Dr. Cernik. You're always wrong. I went to school in Monterrey, but I'm originally from a very small town, Sabinas, Coahuila, which is about 80 miles from Eagle Pass. And it became very famous recently because nearby they killed the major leader of the Zetas. And they took his body to the funeral home of my friends there in my hometown, and they identified and took the fingerprints and photographs and everything. And before they get the diagnosis of being the right guy, somebody came in and stole the body from the cadaver disappeared, like magic realism of Garcia Marquez's novel. So that's my hometown right now. So big fight, big war going on there. Today I'm going to talk about surgery for inflammatory bowel disease. This will take a few slides and just complete volumes to talk about that. And we'll start by the same thing, the incidence of ulcerative colitis and Crohn's disease and the prevalence of both. And you'll see it varies depending where you are. If you are south of the border, the incidence is very low. If you're living in New York or the Northeast Metroplex, then the incidence is very high. And equally for Crohn's disease. And I will not want to go into details of these fascinating new discoveries of genetic origins of the inflammatory bowel disease. Suffice to say that, yes, it's in many cases genetic familial condition, but this is an investigation, a research that where millions of dollars are spent because trying to find the cure for this terrible problem. First, I will talk about ulcerative colitis. And ulcerative colitis is a chronic inflammatory disorder. It starts always at the rectum, and that's what characterizes ulcerative colitis. Starts at the rectum and goes uniformly proximal into the rest of the colon at various levels, and sometimes it progresses from a proctitis to a pancolitis in a matter of months, but sometimes just stays in the rectum and the sigmoid, and it can be very debilitating just in the rectum and the sigmoid. So this is a continuous inflammation. There is no escape areas. We have bloody diarrhea, and that is the hallmark of the ulcerative colitis. They have also the periods of exacerbation and remission, and during the World War II in London, they kept track of the patients at St. Mark Hospital, and they saw an increment of the activity of the disease right after bombing. When the Germans came and bombed London, the number of exacerbation of colitis went up. And it has a bimodal age distribution. It's a disease of the very young, the young people, the teenagers, the beautiful girls that have colitis, and of the old people, well, of the mature people, 60 and above. I have to be careful what I say, Dr. Serenity. And the clinical features of rectal bleeding, the diarrhea, the urgency, and the tenesmus, and some patients complain of constipation. They say, I'm constipated, I'm not having bowel movements. And how many times do you go to the bathroom? Well, I go 10 times, but I don't have a bowel movement. I have blood, and they pass blood, and they have the urgency, and if people live in Laredo, and they come to San Antonio for consultation, they know every stop, every bathroom on the road, because they had to stop. And they don't go to Mass and stay the whole hour in Mass because they had to go out and have bowel movements. And that's indicative of the activity of the disease. In some cases, they have fever, and of course, they have the extraintestinal manifestations. And they vary, and there are large amount of extracolonic manifestation, from the musculoskeletal, which are the most common, the osteopenia, the osteoporosis, the arthropathies, peripheral and axial, the cutaneous manifestation of erythema nodosum and pyoderma gangrenosum, the major extracolonic manifestation of primary sclerosing cholangitis that goes into cirrhosis and cancer and gallstones for some reason, and the iritis and the inflammation on the eye, and the coagulopathy. These patients are highly coagulable, and they develop clots, and they develop pulmonary embolism, they develop obstruction of major vessels. And so all of these things need to be taken in consideration. Just to say that primary sclerosing cholangitis don't go away after you take the colon out, and the pyoderma gangrenosum may or may not go away. The axial arthritis do not go away after you take the colon. And there are many other manifestations. And this is just a picture of pyoderma gangrenosum, an ankle of a man. It's man because he has a lot of hair in the legs. The diagnosis is based on the clinical symptoms of the patient, mainly the endoscopic finding. That's what is going to give you the clue. You look at that rectum, and you see the different types of and degree of inflammation, and the friability of the mucosa, and the granularity of the mucosa, and the absence of blood pattern, the vasculature of the mucosa. Then you can make the diagnosis of presumptive ulcerative colitis, different from Crohn's disease, where you have the linear ulcers and the scoop-out ulcers. And then you take a biopsy, and the pathologist will tell you many times. And this is the picture on the endoscopy, where you have a very mild colitis. Here, the mucosa is edematous. Here is granular and friable. And the other one is more advanced. And there is a classification of the this is a severe case of colitis, where you see necrosis and pus in there. So you judge the acuteness of the colitis by different things. And the severity scale, this is a very old severity scale of True Love, and it's back in the 50s that they've noticed this, and it's modified a little bit. But essentially, it takes the number of bowel movements, the amount of blood that comes in, the sedimentation rate, the hemoglobin on the patient, and the pulse and the temperature. And when you have fulminant disease, you have all of those things that tell you that you have a very sick patient. And of course, the gastroenterologists are great on putting things in the small places and developing these classifications. And this is the Montreal classification, but a few years before there was the Vienna classification, and a few years before they have the Rome classification. They're always changing depending of their spa. You know, they go to a spa, they name the classification after the spa. And so it classified them according to the extent of the disease and the severity of the symptoms. And you can make a good classification from that. And they have one for Crohn's. So what are the indications for surgery on patients with ulcerative colitis? Well, first, we need to save lives. And we save lives when we operate in an emergency situation, an urgent situation. The toxic megacolon, the fulminant acute colitis. We also operate, and the majority of the patients that we operate nowadays is to save a quality of life. The quality of life is the patient that has failed to respond to adequate medical treatment. And that is a very nebulous situation. What is failure to medical treatment? Is that the patient that comes in after steroids treatment for many years with aseptic necrosis of the hips that need to be replaced? Or does the patient that has continuous bloody stools for 6 months, even though they have maxed their steroids and they have maxed the Remicade and they have given this cyclosporine, and all the 5-ASA and all the medication, all the suppositories, and it still has bloody diarrhea. And that is the time to consult the surgeon. And also we operate on these patients to prevent cancer because this is a premalignant condition that increases the cancer rate after 10 years by 1%. It's about 10% at 10 years, and then for each year it's about 1% more. After 20 years, it adds up to about 30%, and after 40 years, it's about 64% incidence of cancer. So the emergency surgery, we do it for toxic megacolon, for the acute toxic colitis. It doesn't have megacolon, but it has a lot of bowel movements, fever, abdominal pain, tachycardia. And the massive hemorrhage, which is very rare. And this is a patient that has toxic megacolon. The presentation of the patient probably is taken Imodium also for the diarrhea and comes in and is distended, not too tender because he's been on steroids. And you take a KUB and it shows there the dilated transverse colon. And why the transverse colon? Because the patient is lying down and the air goes into the transverse colon. Occasionally, you'll see some pneumatosis. That's an indication to go in. If you have a distended colon like this with pneumatosis, you go in. And they have a little scalloping of the mucosa, thick wall. Now you have CT scans that show you also the amount of inflammation in the wall. And this patient, you have to be very careful and work hand in hand with the gastroenterologist. Because initially you need to treat that patient medically with LPO, the NG tube, the fluids, the replacement of potassium that may be very low because of the steroids, and you give all of those things. You repeat the KUBs to be sure that you have it perforated or that the picture is not getting worse. But my preference is that you stabilize the patient and then you operate. And then you operate because they tell me, well, he's not psychologically prepared, then he will be psychologically prepared when he perforates. And the next day you go and see, and then you have free air, and then the mortality goes up. A few years ago it was 50%. I think it's less now. But perforated toxic megacolon is a very, very serious problem. So you do a total abdominal colectomy, you leave the rectum, and you may treat that with a mucous fistula, which is not my preference, but it's the preference of many surgeons throughout the United States, where you take all the colon and you bring the sigmoid as a mucous fistula that always gets infected and a mess. Or you can do a Harman procedure, be sure that you tag that distal segment with a prolate. Now, this operation for toxic colitis, not so much for the toxic megacolon, you can do it with the laparoscope. And there is enough evidence now that the operation that is done with laparoscopy, with total abdominal colectomy and ileostomy, is safe, can be done with a minimal amount of complications, and it takes you longer, but it saves the patient problems. Now, you leave that rectum in there. And this is the picture of a colon with toxic megacolon. And as you can see in this area, this ulcer, look at the depthness of that ulcer. That ulcer has necrosis and inflammation all the way to the muscularis propria of the bowel, and that's the reason why the colon is distended, because it doesn't have peristalsis, because it has necrosis and inflammation. And then you see something like just a layer of peritoneum of the serosa of the bowel ready to perforate. So this is the picture of a toxic megacolon. So you operate and then you go and save that life and wait. But the objective for surgery, for elective surgery for ulcerative colitis, is to eliminate the mucosa, and then therefore we cure the patient. If we don't have colon, we don't have colitis. We try to preserve the anorectal function, and then we rehabilitate the patient. Either we give a ileal pouch anastomosis or we give him a permanent ileostomy. We need to rehabilitate that patient and put him back in the workforce. And the choice of operations are the restorative proctocolectomy of ileal pouch and anastomosis, the proctocolectomy and ileostomy, and these two are the mainstay of the treatment of ulcerative colitis, the pouch and the permanent ileostomy. Occasionally, we will have individuals who will do a total abdominal colectomy and ileorectal anastomosis. The patient that has metastatic colon cancer, the patient and a fairly less inflamed rectum, the patient that has cirrhosis, the patient that just doesn't want an ileostomy and doesn't want an ileoanal anastomosis, and we can temporize. As a matter of fact, in France, before the ileal pouch anastomosis, this was the operation of choice. And you see the patients with a glass half empty or half full. They tell me, 50% of them, they do very well. And we save them an ileostomy. But when the ileal pouch came over, they went over and do ileal pouches. And then an operation that is not very popular nowadays is the proctocolectomy with continent ileostomy or CUP, that we started doing about 1970 and then had too many complications. So if the patient is an emergency case, is malnourished, it has all the nice immunosuppressive medications, biological, expensive treatments. And then we'll do a 3-stage procedure. We'll do a total abdominal colectomy with a ileostomy. We'll do later on, about 4 to 6 months, when he has recuperated and is with good immunity, good nutrition, we do the proctectomy and the ileal pouch anastomosis with the loop ileostomy as a second stage, and then we do the closure of the ileostomy. Otherwise, if the patient is in good condition, is, let's say, prophylaxis for cancer, we do the 2-stage procedure. And we like to do the 2-stage procedure because we would like to protect that ileal pouch anastomosis from sepsis, from severe sepsis. We cannot prevent leaks from, by placing an ileostomy, but we can prevent severe pelvic sepsis by placing an ileostomy. And very occasionally, I think in the last 32 years that I've been doing this procedure, I have done 5 patients with ileal pouch anastomosis without ileostomy, because in about 3 of them, the obesity of the patient was such that precluded me from bringing the loop ileostomy out. So this is a phrase from Dr. Bergen. I think Dr. Pestana knew him at the Mayo Clinic. He was the first one that used cortisone for ulcerative colitis. And the patient can walk to the autopsy table because they look so good, doing so great, feels very good. Keep giving them that, and they walk to the autopsy table. And this is such a lady with 5 years of prednisone. Under these circumstances, we did a proctocolectomy and ileostomy and did not do a pouch. And this is another indication. I had a patient that had gigantic pseudopolyps. The colon feels like it has a rat inside. Huge, all benign pseudopolyps. As you can see there, all of these are pseudopolyps. Now, how do we do a proctocolectomy? That's Spanish. It's not a spelling problem, Dr. Cernik. First, we explore the patient and so forth. We have him in a tolerant position and with a Foley. And then we divide first the terminal ileum, and being very careful to divide these vessels here. This one, perhaps we keep it. The ileocolic branch will keep it. Then we'll complete the proctocolectomy, and we may place a staple down below, flush with the levator ani muscles, and divide the rectum. Now, a little tricky to gain length on the pouch without compromising the blood supply. And one of the tricks is to divide this vessel so you can get length in here and do not sacrifice the ileocolic, because that's the main branch. And so you had to have your Doppler there, you feel the pulse, and you take good care of that pouch being intact, because you need length to go down and do a true ileoanal. So you measure the pouch, you bend that loop 20 centimeters in length, and then you open at the apex, and this is the way we do it and describe it in a published paper. And we open the apex, and then we insert the linear cutter and use that 3 times if you have a 70 millimeter linear cutter to give you a 21 centimeter pouch. By telescoping this ileum over, then you bring that pouch down and you do a hands-on ileoanal anastomosis. And this is the original drawing and the publication of Ramos and Bodie. And you put a couple of drains. That is a Penrose drain for some of you that don't know Penroses. We don't use it anymore. And or we can do a double stapling technique and put the anvil of the ILAs or the EEA and do a staple anastomosis. Occasionally, I place the purse string right at the dentate line after I have taken all the mucosa, doing a hand mucosectomy, and staple right at the dentate line. And we put an ileostomy to protect that, either a complete diverting ileostomy or a loop ileostomy. But we can do this also with single incision laparoscopic technique. On this particular case, we place the port at the place where we're going to put the ileostomy and perform all the operation through there. As you can see, there is no other ports. But the majority of the patients nowadays, we do it laparoscopic proctocolectomy with a pouch and anastomosis. Number of complications with the ileal pouch and anastomosis. Lots of complications. That's the reason why you bring the patient down before the operation and go over everything. And you say, do you want to have a permanent ileostomy, or do you want to try one without permanent ileostomy? Never to be perfect. You're going to have 6 bowel movements a day, but you will not have an ileostomy in the majority of the time. But a number of complications. Leak of the IPA, the ileal pouch, pelvic sepsis, fistulas, portal vein thrombosis, you name it. And pouch failure, about 4%, maybe a little higher. And another very frequent complication is intestinal obstruction. But you have intestinal obstruction if you do ileal pouch and anastomosis or if you do a proctocolectomy and ileostomy. The incidence of intestinal obstruction is the same. Not all the intestinal obstruction requires surgery. It's more frequent in patients without protective ileostomy. Less frequent in the patients that have 3 stages. Less frequent in patients with laparoscopic procedures. So those are the numbers of on 1,178 patients. Intestinal obstruction in 272, and patients that require laparotomy, well, 72. And the risk of intestinal obstruction increases with time. The other problem is sepsis, intra-abdominal sepsis, or the anastomotic failure with the different types of abscesses and fistulas, early or late. Late is after you close the ileostomy. sepsis is greater when you do the pouch on patients with ulcerative colitis than those with familial polyposis. They're higher in patients that have been on steroids and Remicade, on patients that have malnutrition, and those that have severe proctitis, the ones that have toxic megacolon, and those that have undetected Crohn's disease. And the risk of these patients to have sepsis depends on the experience of the surgeon, and the learning curve is about 30 ileal pouches. If there is tension in the anastomosis, very important, or if you have a staple or hand stitch anastomosis, higher on the hand stitch. And your fistulas can come from the proximal loop or from the anastomosis, and they can go to the perineum or go to the pelvis, and you can have a pelvic abscess. And on one particular patient that had a disruption of the dehiscence of the anastomosis early, postoperatively with this patient had an ileostomy, but he had the disruption, the anastomosis, and I can feel the defect. So I took her back to the operating room, and thank God I left the omentum. And I think most of the time we would like to leave the omentum in place because this is good to patch plugs. So I brought the omentum through the defect and closed that defect with a patch of omentum that extruded into the anus. She was defunctionalized, so it went fine. And this is a portal vein thrombosis, common. Now that we have good imaging technique, we'll see it more and more. About 7% will have these. They come in with abdominal pain and nothing else. When you do a CT scan, then you find the portal vein thrombosis or hepatic vein thrombosis, and then you anticoagulate them. Now, this is a unique case where the surgeon did not go down enough, did not remove the rectum, did an ileorectal anastomosis, and this rectum stayed very inflamed and give trouble. So that had to be removed. You can have strictures, urinary dysfunction, sexual dysfunction, about 2%. And you can have pouchitis, which is the condition that 60% of the patients at some point develop. About 15% will have relapsing symptoms or become refractory. It only occurs on patients that have ulcerative colitis. It doesn't occur on patients that have familial adenomatous polyposis and have the same operation. And we treat it with metronidazole or Cipro, or because it may have a component of bacterial component. And this is the mild pouchitis and a very severe pouchitis, as you can see on this slide. These patients have perhaps a dysbiosis, or they have identified a number of genes on these patients that make them very, very prone to have recurrent pouchitis. They have some unusual cases of C. difficile pouchitis or infection or ischemia. Ischemia is a big factor. And you need to classify them as antibiotic responsive, antibiotic dependent, or refractory, and go over the algorithm of how to treat it. And you can give them probiotics. So at some point, you may need to remove the pouch from pouchitis, and that's an extreme case. You need to rule out Crohn's disease. Now, there's some myth that are involved in the treatment of ulcerative colitis. The failure of medical treatment is the failure of the medical gastroenterologist. That's not true, Dr. Parker. Not true. It fails because the patient's fault. Don't feel guilty of giving the patient to the surgeon. And then the patient is not psychologically prepared. Who is prepared for a ileostomy? Nobody. Intensive psychiatric treatment do not make any difference. Also, the patient that have proctus sigmoiditis, well, just remove the distal part and do a coloanal and they'll do well. Wrong. You need to take all the colon out. And there is no risk of cancer in quiescent colitis. The risk is there. Now, this is Crohn's disease. I think these slides are out of sync. But let me just go. Let me, can somebody get, okay. I'm just going to say a few things about Crohn's disease. We operate Crohn's disease for complications of Crohn's disease. This is an incurable condition that we just need to palliate. And we need to find the adequate time to operate. If we have abscesses, we drain the abscesses. If we have phlegmons and have maximal treatment, then we can go in and resect that part of the intestine and put the things back together. We can do, if this patient have severe problems like this obese patient with Crohn's disease, we do proctocolectomy. With an ileostomy, on this patient we found a gastrocolic fistula with involvement of the jejunum, 3 strictures in the colon, and a rectovaginal fistula. We cannot treat that medically. Rectovaginal fistula with all of these other complications, that is no place for how many thousands of dollars of Humira do you want? How many, another year of treatment and see if the fistula heals? It's never going to heal. So that's the stricture. And so we see patients with Crohn's disease in obese patients. 62 patients on 2,065, 3 obese. They don't have any difference in sex, intestinal location of the disease. They have more anorectal complications on the obese patients. And they can develop pyoderma gangrenosum of the ileostomy, and this is a very terrible condition because the patient is not able to pouch well. But mainly on patients with Crohn's, with active disease, treated by having the ET nurse go and see her or him. We may do debridement. We may inject steroids under the ulcer, or we may relocate the stomach. Or we may give Remicade with 80% response. So this is the patient that we don't want to see, the one that has severe perianal sepsis, that has refused to have anything there, and later on ends up with ileostomy anyway. So the treatment of inflammatory bowel disease is extremely complicated. It requires a lot of interaction between the gastroenterologist and the surgeon. It has to be treated by both of them with consensus. And then we can have better results. Thank you.
Raul, there are other myths too, and I just wanted to ask you your opinion. Is there a higher incidence of cancer in those with ulcerative colitis where it's pan-colitis?
Yes, the length of the disease, the age of the first episode is important. The distribution of and the extent of the disease in the colon is very important. Higher in patients that have pancolitis, but nevertheless, on those that have left-sided colitis, it's about 10% less than the ones that have total colonic involvement. They still have it. They never had it when they have only proctitis, with the ulcerative colitis, but left-sided colitis they do have. Crohn's disease, same way. And higher incidence, and maybe genetically compound on patients that have the cholangitis, the sclerosing cholangitis. Those patients are more prone to have cancers. Now, the question is, patients that have sclerosing cholangitis, and they have an ongoing inflammatory changes, and they have developed cirrhosis, and they have portal hypertension, which one do you operate on? Do you do proctocolectomy with pouches on those patients? Or do you want to do liver transplantation first and then the pouch? Or you do a proctocolectomy and no pouch? Or you put a tips first? And we had such a case that I haven't followed up, but last April they had one in the gastroenterology department with a bilirubin of about 15, bleeding tremendously from the pouch or from the rectum, because of viruses, not because of active colitis. The viruses of the rectum. And do something. I'm not going into that pelvis with portal hypertension. The tips will do, or transplant it. It's a different deal.
Is the colon cancer, I know Dr. Santiago is here, is this a myth or urban legend or truth? That the malignancy, the colon cancer, is more aggressive in people with inflammatory bowel disease? But this has come up many times.
No, I think it's stage by stage is the same. What happened is that the patients that have ulcerative colitis are diagnosed to have the cancer at a later date when they are more advanced, because they have common symptoms: rectal bleeding, the colon cancer, and rectal bleeding and ulcerative colitis. They still think that they have ulcerative colitis. So, and also because the reluctance of having colonoscopy every 6 months. Now, the fact,
you agree, Dr. Santiago?
Yeah, I think it's the same prognosis, just delayed diagnosis, like Dr. Ramos is saying.
Stage by stage.
Stage by stage, the same. The stage migration of these patients get delayed.
What about race? I mean, one of the things we always talked about, that there's a lower incidence in our African American population with inflammatory bowel disease, and also in our Hispanic population. Is that true?
Pretty so. Well, more common on Ashkenazi Jews than the Mediterranean.
When we talk about the Northeast, one of the interesting things is it extends up into Canada.
Right.
And you've seen the distribution there compared to mid-Canada or Western Canada.
The most important papers from epidemiology and demography of inflammatory bowel disease come from stable population of Olmsted County. Olmsted County is Rochester, Minnesota, for all practical purposes, and they keep the people stay there.
Two quick questions, please. First, what exactly is Remicade? Is that an antimetabolite? Is that a steroid? What is it?
It's a biological
Immune modulator.
Anti-tumor necrosis factor. Anti-tumor necrosis factor.
Okay. And the second quick question. I've heard, I had heard in the past that the abrasives that are used to polish teeth, if you swallow those will eventually get into the mucosa and give you Colitis. Is that true, or give you Crohn's disease? Is that a myth?
Haven't seen that.
Never seen that.
You're going the wrong category.
Well, next time I'll go ahead and swallow the damn thing.
Yes, Dr. Parker.
Ulcerative colitis for cancer and dysplasia, and the risk is about the same for Crohn's disease, they say. But we can't get there because of strictures and lumps and bumps, and it's a terrible problem. When should we snatch that colon out for cancer?
Well, I think that when you think about it, then you do it. But keep your friendly surgeon in mind, because it's very humble experience to be following a patient for many years that suddenly shows up with cancer and you were not able to prevent it or be on time.
Some of the tricks about the pouch.
Yes.
Is that if you take it out of the abdomen where you have the pouch and it can reach the pubic bone, it'll reach the anus very nasty.
You put your...
And you could also make relaxing. You don't have to necessarily take the blood supply like you should. You can make relaxing incisions in the mesentery, which will also help with them.
I think you have to take that blood supply and do relaxing incision. Now, the trick is before you take that blood supply, you identify the vessels that you're going to cut, and then put a vascular clamp in there and wait. And wait and see if there is enough collateral circulation, blood supply that will keep that pouch available. And be sure and don't twist that pouch at the time that you bring it down, because then you can get obstruction.
One of the biggest arguments against the ilioanal J pouch was continence. And I distinctly remember the Mayo Clinic presenting their results on multiple occasions. But still, 20% of people have incontinence. Usually it's at nighttime. Is that correct?
Nighttime incontinence is about 6%, but you have to look at it on time. You know, I have patients that I have done a pouch 25 years ago. They have 2 bowel movements a day. 2 bowel movements a day. Why? Because that pouch has grown to be a true reservoir and can hold. So it takes with a...
Want an ileostomy because it's turned out
those patients are very few.
Are they?
The one that want to have an ileostomy back, or the one that have 20 bowel movements a day because they have Crohn's disease. And that's common. Indeterminate colitis is about 10%. But because of our pathologies are not geared to call it indeterminate colitis, they'll say ulcerative colitis. They have ulcerative colitis, and then 5 or 10 years later, the patient comes back with classical Crohn's disease. So my former partner, Dr. Rosenthal, used to say, the diagnosis of Crohn's disease, of ulcerative colitis in a resected colon, the slides have to be on storage for 10 years before they go and make the diagnosis. Give the chance to the patient to declare it himself which one is going to go. And they come as Crohn's disease. And we reviewed the specimen and the pathology and everything. It was ulcerative colitis. So, bad luck.
So tips with respect to avoiding putting a pouch in someone who has Crohn's. How do you you have a large experience. How do you try to pick those? It would be best to pick those patients out ahead of time.
Absolutely. Yes, the patient, the scenario is like this. The patient has colitis. So it's inflammatory bowel disease just in the colon. And then the patient tells you, you know, doctor, I had a fistula. Then your alarm go out. He has a fistula. Then you're going to say, is the fistula going to be preventing me from doing a pouch because he has Crohn's, or after they operate, the sphincters are not that great because they divide the sphincter. So you have to rule out that. Then they can do serology, which I don't trust, and I don't think anybody trusts this. You trust the serology? What you order them? You order the serology. You do not order serology. Well, other people will order serology, and they put a lot of emphasis on serology. I don't think so. It's not good. Not enough. Not enough evidence there. So you may have to scope that patient yourself and be sure that you don't have skip areas. And if you have skip areas, that's not ulcerative colitis. That if you have a normal rectum, that is not ulcerative colitis. That's Crohn's. So the diagnosis is a clinically endoscopic diagnosis. Forget about the biopsy. If they don't have granulomas, doesn't mean anything. If they have granulomas, yes, most likely it's Crohn's disease. But if they don't have granulomas, can go both ways. So.
Yes, Dr. Rittenhouse.
How long are you willing to manage these people medically before you worry about colitic cancer?
But many of those patients that come in with cancers are not, they're quiescent. They're not symptomatic on that. But I think that after 8 years of the disease, then you have to be alert of the possibility of colon cancer, because at 8 years it's about 5%. And you have to be looking at it, doing colonoscopy and taking random biopsies, about 37 biopsies. How many biopsies do you take? Plenty of biopsies all over to be sure that they don't have dysplasia. Now they had to be on quiescent state when they took the biopsy, because high-grade dysplasia is very common on acute inflammation. They cannot distinguish that from the other. And if they have acute dysplasia, then it's about 60% that they have carcinoma.
The standard.
Well, because there are a number of patients that at 10 years, they already had the carcinoma for 2 years. So you want to get them early, you have to start at 8 years, 7 years, at some point.
Dr. Ramos, a good talk. What is the relationship between sarcoidosis and Crohn's disease? As you remember the big Morrison from St. Mark, they think sarcoidosis, it's Crohn's disease because of the granuloma you just mentioned.
Right.
One.
So it's tuberculosis, right?
Well, it's not. There's no Koch bacilli, but there's a granuloma, exactly like sarcoid.
Could be in the same unknown, but I think the pendulum is moving into finding a culprit that may be a bacteria. What do you think, Dr. Parker?
In Australia and other places, they're stirring that up pretty good. They may come with one.
They may come with one, because this behaves very much like a bacterial condition. And you're right, sarcoidosis may be due to a bacterial condition, or a viral, or something like that.
The other question I want to ask you, if you have a patient very, very sick with toxic colon, Do you still do, you think the turnable has any role here? How do you treat him? Very sick, on a pressure, blood pressure down the chute, and toxic colon. How do you?
Yeah, then, but add one more point, because that what's holding the calling to the surgeon is that that patient has also Clostridium difficile. And that is what muddles the water, because the gastroenterologist say, well, he has Clostridium difficile colitis, and we do not operate for Clostridium difficile colitis. But we operate for toxic megacolon of Clostridium difficile colitis. But the Clostridium difficile colitis in a field of ulcerative colitis is a very good marker of decreased immunity. And then if it shows with acute toxic colitis or toxic megacolon, you have to operate that patient. Now, if he's in pressure and so forth, you put him to a place where that would tolerate the anesthetic. And then you take him to the operating room. You take the colon as fast as you can, hopefully not with the laparoscope. You can open, take that colon in 45 minutes, put an ileostomy. That's it.
Patient with turnable used to do?
You know, that is a very nice historical perspective. That's what it is. Now, the only place where they defended still and they find a patient that can do it, a pregnant lady that is almost to the, things like that, is at the Cleveland Clinic, because they have that picture of Trooper Turnbull there. Pay homage to the man.
He should be remembered for many other contributions than that.
Well, I think from alerting to many other things, construction of ileostomies, pull-throughs, no-touch technique, et cetera, et cetera.
All righty. Thank you very much.